Thank you. Good morning. So I have no disclosures. And I just want to talk about why pericardial disease is important. I think it needs to be on our clinical radar because it can present with so many different clinical syndromes and in different clinical settings. And pericardial diseases carry significant morbidity and mortality. We need to correctly diagnose these diseases in order to appropriately guide management. So echo is first line in the assessment of pericardial diseases, and CT and cardiac MRI are able to provide incremental information to both the anatomy and physiology that is initially assessed on transthoracic echo. So using the guidelines, the objectives of this talk is to highlight the diagnostic role of echo in these three clinical scenarios: acute pericarditis, constrictive pericarditis, and pericardial tamponade. We'll have an opportunity later this afternoon to hear from the lead author on those pericardial guidelines. So, kind of the quick and dirty of anatomy, pericardium has two layers. In between, there's approximately 10 to 50 mils of pericardial fluid, which is an ultrafiltrate of plasma. And the pericardium encases the entire heart, as well as the proximal portions of the great vessels, so the aorta, pulmonary artery, vena cava, as well as the pulmonary veins. Okay, so acute pericarditis. The diagnostic criteria requires two of the following 4 points: a typical chest pain syndrome, on physical exam a pericardial rub, ECG changes that are consistent with pericarditis, or a new or worsening pericardial effusion. So there's a role in echo for all patients who have a suspected diagnosis to help hit that diagnostic algorithm. CRP and ESR can be additional supportive data for the inflammatory process. And in equivocal or refractory cases, we can move on to cardiac MRI to also look for signs of edema and inflammation. So all patients with a suspected acute pericarditis should get a transthoracic echo. In the guidelines, they say it should be obtained within 24 hours. We're going to look for effusion as part of our diagnostic algorithm, and we'll also look for complications: tamponade physiology, constrictive physiology. We can screen for myocardial involvement in a myopericarditic process, and it can give insight into etiology. But it should be known that there's nothing that's pathognomonic to confirm the diagnosis, just supportive when we talk about echo. So my clinical case is a 38-year-old gentleman who presented with a retrosternal non-radiating chest pain that was made worse with deep inspiration, as well as laying flat. Initial presentation, he had stable vitals. His JVP was up, but he did not have a Kussmaul's. There was no pulsus paradoxus, but a rub was appreciated. And the ECG showed PR depression with isolated ST elevations inferiorly. So he's meeting criteria for acute pericarditis. But he went on to have an echo for further evaluation. We can see anterior to the right ventricle, the outflow tract, that there's an echolucent space, which is consistent with an effusion. Now, most commonly, acute pericarditis is secondary to a viral or idiopathic etiology. And when we switched over to the peristernal short axis views, what was highlighted or came to our attention was that this was not a simple, uncomplicated viral pericarditis. You can see this heterogeneous mass that's occupying the majority of the right atrium, crossing tissue planes, and also extending into the right ventricle. So the guidelines then also mention how CT and MRI should be used in cases of acute pericarditis that have complexities that are associated with the presentation, which this case certainly showed. And on the CT scan, all we can see is this large mass. It measured approximately 10 by 7, occupying the right atrium, extending into the tricuspid, across the tricuspid valve into the right ventricle, and also through the myocardium into the pericardial space. And this patient was diagnosed with large diffuse B-cell lymphoma, and he was treated with CHOP and radiation. So, key points: echo is part of the diagnostic algorithm. No finding is pathognomonic. It also helps in the assessment of complications and can give insight into etiology in rare cases. Constrictive pericarditis. So constrictive pericarditis occurs when we have a non-compliant pericardium. And in chronic cases, this is because of fibrosis and calcification, but there's also subacute processes that are the result of significant inflammation. And what is affected physiologically is that diastolic filling. So you have early rapid filling until there's constraining features of the pericardium. And what we will see is that there's unique pathophysiology, and using that, we can use echo to make the diagnosis. The thickness of the pericardium is not pathognomonic. In up to 18% of patients, you can have normal thickness, but still have constrictive physiology. So what we look for is the presence of dissociation of intrathoracic and intracardiac pressures. That abnormal pericardium kind of isolates the heart to what's going around, changes in the pressures that are happening in the thorax with respiration. Because you're in a relatively fixed cardiac volume with that constraining pericardium, there's an enhanced interventricular dependence. There's also unique relaxation properties that we will see because of the tethering that can happen with the abnormal pericardium, as well as I said that there's early rapid diastolic filling because it does not get limited until the effects of the abnormal pericardium occur. So this is a video that's actually from Mayo that visualizes gives us an idea of what's happening pathophysiologically. So with inspiration, intrathoracic pressure drops, but that's not transmitted to the cardiac structures. So we have a decreased effective filling gradient. At the same time, with inspiration, we have increased flow into the right side of the heart, so the septum shifts. So we'll see a drop in the E velocity of the mitral valve, a septal shift towards the left ventricle, and we'll see augmented forward flow with diastole to the right side of the heart. With expiration, that filling gradient is restored to the left side, so we'll see an increase in the E velocity. To accommodate that flow, the septum moves to the right ventricle, and so you get a reverberation of pressure back into the hepatic vein, and we'll see that increase in expiratory diastolic flow reversal of the hepatic vein. This video also will illustrate on the far side constrictive pericarditis. We get exaggerated septal myocardial motion, and that's because that heart's trying to accommodate filling, but we have that tethering of the lateral wall. One of the mimickers can be myopathic process, and so E primed is reduced, and you can see on the far side normal. So using those principles, the studies have shown and tried to come up with a diagnostic algorithm. So this was adapted from data that was published a year after the guideline, but I find that this is a helpful way to walk through and simplify our diagnostic approach. So there's 5 key features. 1, IVC plethora and a mitral EA ratio of 0.8, which tells us there's high filling pressures and that there's early diastolic filling that predominates. Then we look for the enhanced ventricular dependence with the septal shift, and we look for the abnormal or unique myocardial relaxation with that E primed or equal to 0.79. So 5 points that we're going to look for in that initial diagnostic screening. So we will look at that algorithm through this case, a 42-year-old who presents with incessant pericarditis. As he was being tapered down off his anti-inflammatories, he presented with recurrence of his pain, and he also developed right-sided heart failure symptoms. So first, we look at the IVC. It's dilated with reduced collapse. 2, we look at the mitral valve inflow. The EA ratio was 1.8, so early diastolic filling predominating. It did calculate out inspiratory variation, and there was inspiratory drop of 26%. If you remember, the echo math is expiratory minus inspiratory divided by expiratory. Then looked for ventricular septal shift, both with 2D and with M mode. So it was a shift towards the left ventricle with inspiration. Tissue Doppler, the E primed, was 0.9. And looking in the hepatic vein, we look at, first we use the ECG to identify diastole, then we look at the respirometer to identify expiration. And to calculate the diastolic reversal ratio, we take the velocity of the reversed portion of flow, which was 0.35, and we divide it by the forward, which was 0.19. And it exceeds that ratio of 0.79 that we're looking for. It's 1.84. So these meet the criteria for constriction by echo. And we often use the incremental data from CT and cardiac MRI to look at anatomy, as well as other physiologic factors on the cardiac MRI cine imaging. And this patient went on to have that, and we can see on these two T2 weighted spare imaging a thickened pericardium measured 10 millimeters, normal is 2, and we can see how bright it is, which is consistent with edema. So echo is an initial diagnostic test. We look at both 2D Doppler and tissue Doppler to look for constrictive physiology, and 5 high-yield points are the IVC, mitral inflow, respiratory septal shift, medial tissue Doppler, and hepatic veins. And the last, we'll be looking at pericardial tamponade. And we can see with tamponade, fluid accumulates in the pericardial space. When volume increases, we get an increase in pressure. And the rate of rise of pressure will depend on if it's an acute or chronic process. When the interpericardial pressure exceeds intracavitary pressure, it affects transmural filling and we get chamber collapse. It's a fixed volume, and that increased pericardial pressure is throughout the cardiac cycle. So a little bit different than the physiology of constriction. And so what we will get is enhanced interventricular dependence, as well as we have to have increased filling pressures in order to try to preserve filling and maintain cardiac output. So echo looks at the effusion and the hemodynamic effect, but remember, tamponade's a clinical diagnosis. So our pieces that we look at from echo, both M mode and 2D, we're going to look at early diastolic collapse of the RV, so around the T wave, late diastolic inversion of the RA, and that's a sensitive marker, and it becomes more specific if it extends throughout the cardiac cycle, greater than a third. So again, this happens when the pericardial pressure exceeds the intercavitary pressure. The abnormal septal motion is consistent with that ventricular interdependence and also drives the variation across the mitral valve and the tricuspid valve. The numbers of drop are different. We're talking 30 and 60% with tamponade. The IVC, of course, should also be dilated with reduced inspiratory collapse, indicating the increased filling pressures. So the patient here, 35, and he was stabbed, hemodynamically unstable, JVP was elevated, pulmonary congestion, muffled heart sound, so everything was pointing towards clinically of tamponade. The echo was obtained to see where do we go from here. We can see that there is this pericardial effusion anterior to the right ventricle and a large pleural effusion as well. We can see that there's chamber collapse of the right ventricular free wall, and then on the M mode, we can time it, and we can see that it's early, it's around the T wave. In the bottom image, we can see the abnormal septal motion, and again, that free wall collapse of the RV. Looking at Doppler, there's an inspiratory drop in the E velocity of 35%. Across the tricuspid valve, 61%. The IVC is big and did not collapse. And on the bottom, we have Doppler of the aorta, descending aorta. We see variation in peak velocities, which would be the echo equivalent of pulsus paradoxus. So he went on to have an echo-guarded pericardial synthesis. But again, the key point, tamponade is a clinical diagnosis, and it's a hemodynamic spectrum. And so our job is to go through those parameters to see the extent of the effect. So in conclusion, echo is our first-line imaging tool in pericardial disease. we use it in the role of diagnosis as well as detailing hemodynamic effects. Thank you.